And I am as a Master of Ceremony today. I would like to read our agenda today. First is opening. The second is speech of the Dean of the Faculty of Health. And the third, lecture from Sanguine Blood Bank, the Netherlands. And fourth, Q&A session. And the last is closing. And in the closing, we have souvenir exchange and also group photos and signature for the implementation arrangement, Dr. Hans. Okay, ladies and gentlemen, let's begin our event today with say Basmalah together. Bismillahirrahmanirrahim. First is the speech from the Dean of the Faculty of Health to Ms. Ida Nursanti, MPH. The time is yours.
PhD, and also representative of PT RMK Diagnostic. I strongly agree with blood bank program study to hold the event with collaborated with practitioner expert, especially from Sanguine Blood Bank in the Netherlands. Dear all speakers, thank you for accepting our inviting to become the invite lecturer today. I wish you gain some benefit and enjoy in this event. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Mr. Ida, for your speech. And ladies and gentlemen, we enter to the main of the agenda today. The first lecturer from Dr. Hans. Okay, the time is yours, Dr. Hans. Dr. Hans will explain to you about the basics of platelets, why to transfuse, when to transfuse, and making the choice for the correct platelet to transfuse.
Do we have something to continue with the slides? Selamat siang.
Selamat siang.
I think I do it in this way. I'm not speaking Bahasa Indonesia, only a very few words. I was here in Indonesia now maybe the last few years 30 times, and it's already, so I have been a lot of times on the other university at UGM, and 3 or 4 years ago I met Francisca, Ibu Francisca, and you I met, and they requested me to come and to give some lectures for you. Unfortunately, we had some virus that thought that could survive of us, but we survived, as you know. So, can we have the slides? So, MD, PhD, what is it meaning? Doctor. I'm transfusion medicine specialist. What is it meaning? In your terminology, I would be SP, PK, K. So I'm working for the sanguine blood supply. But the sanguine blood supply is nothing else than UTT, PMI, lambda. That's all. So, my daily work. So, can we have a switch that I can point something and... I have no financial disclosure to make with this presentation, but this trip is being paid by Merck and partly by sanguine reagents, and so the flight and the accommodation is paid for. Oh, I have to say it next? Or, okay. Then I go and stand here, but the people on the screen can't see it. Okay. We have a patient. We have a patient. She is born in 1957. She has 5 children. She is born on Sumatra, Padang, and she came in your clinic with the disease of Kahler, in other words, multiple myeloma. You start with treating her with lenalidomide, dexamethasone, and daratumumab. Yes, next please. Next please. Next please. What you do see in this is that 5 days after the start of the treatment, you need to give blood. So what you see is she is AB negative. Very rare here in Indonesia. Only 2 in 1,000 people of you have D negative. RHD negative. Hemoglobin levels are reasonable, 11 grams per deciliter, hematocrit of 33%. The white blood cell count is 300. Oh, that's low. And the platelets are 4,000. That's low, isn't it? Yeah. So she is in a neutropenic and in a thrombocytopenic state. We decide to give her platelets. Yes, please. So this is normal. Platelets, when you are going to start in a patient with leukemia or with a disease of Kahler, after 4 or 5 days, you see a drop of the platelets and you need to transfuse platelets. It's completely normal. Okay, we decide to give platelets and we are going to call donors for platelets or take platelets from the shelf. Yes, please. So, what to do? Yes, please. Next slide. Do we really need to give platelets with 4,000 platelets? What we know is from studies. Because do you know what could be happening when you don't have platelets? Is anybody knowing what could happen? You can get bleedings. But how is this? When you have this, you see here the platelet count, and this is the platelet count, and this is the possibility on bleeding. So what you do see is that when you are below the 10,000, you can have an increased risk of bleeding. So between the 10,000 and the 100,000, there is no difference. Next slide. And Professor Slichter from the United States did a study. She studied into the stool, the poop of patients, how much blood is in it. And what she did is looking for it. And what she noticed in this is, and this is published in 2011, but these are studies from 40 years earlier. That's easier. That's not. Thank you. So you see that below 10,000, 10 times to the 9th or 10,000 per microliter, you have an increased risk for bleeding into your stool. And based on this, next slide, can I do it also here? Next slide, please. Next slide. Okay. Yes? No? Previous. Previous one. Can I do it for myself? Oh yeah, here. Oh, yeah. That based on this, internationally was recognized that you don't need to give platelets below the 10,000, above the 10,000, unless you have to do surgery, brain surgery, eye surgery, etc., or specific things. What we do know from the practice in our oncology patients is that you give platelets a few times, to be exact, 7 times in 12 days or so, and then the patient is making its platelets again. So this is normal. So we give, again, platelets after 2 or 3 days, then it drops again, 2 or 3 days, until the patient is making its own platelets again. So, what is a dose to transfuse? Do you have any ideas? The question is giving more better? What do you think? What needs to be in the bag of a platelet? You working in health, are going to work in health, need to understand what is in a dose. Because we as doctors want to know when we give a blood component, what's happening in our patient. So, do you think that this Big Mac or double burger is good for us? Ja or tidak? Tidak, eh? No, I think so. Okay, same is with our plate. The same is with our platelets. So there was a study done, which is named the PLADO study, platelet dosing study. And what they did do is, they had many patients, 1,300 patients, and they had to give them, later on appeared, about 5,500 transfusions. And they were randomized. This group gets only platelets when it's below the 10,000, and then compared to was 1.1 per square meter of your body surface. This group gets platelets also below the 10,000 and always 2.2 times per square meter. And that group, a little bit less group, gets the best. 4.4 times, 10 times to the 9th, to the 11th per square meter. A very high dose. So, how to check then? I told you below the 10,000 we are afraid of bleedings. So what you did do is they sent in every morning 2 doctors to check all the patients whether there were bleedings. And they didn't know how much platelets were given. Every morning, every evening. So every 12 hours was checked and was scored. And after deblinding the study, it appeared the next one. Low dose platelets, of course you give more in time, maybe once in 2 days instead of once in 3 days, but in total you give less platelets. And there was no effect. So you're the best group. But you already knew, I think. Isn't it? That you are the best group? Be happy for yourself. Come on. No? Okay.
Yeah.
What is the body surface area? Do you think that I have the same body surface area as you? Is this typical American having the same body surface area as ladies like you? I don't think so. So we need to have more information on that. So the body surface area has to do with, of course, with the length and the weight of us. And when I see here, taking into account the body surface area, so when you're 1 meter 80, I think there are not many people here that are 1 meter 80. And 70 kilograms, you have a body surface area of 1.9. Then you need, with this 1.1, 200,000 or 210 times to the, 2 times 10 to the 11th platelets, which is 210 times to the 9th. When I would have this, I have a body surface area of 2.2, so I am around 250. Look at yourself. Look at yourself. The mean weight of the Indonesian woman at age of 45 or so, 40 to 45, is about 47 kilo. 47. Let's say 50 kilograms. So your body surface area is not that big. So this is more than enough. These amounts in your blood system are more than enough. Okay, so we decide, based on what I told you, that when we have a need for platelets, is that it is below the 10,000 per microliter in your patient. And you don't give more than 2.5 times 10 to the 11th. That's 1 adult dose. So we have a platelet count of 4,000, so we need to transfuse. We give doses. But then the question is, it's blood type AB. AB negative. Tell me, what do we need to transfuse? Do you know what the percentage is of AB in your population? About 5%, 5 and 100. What is AB negative in your population? It's 0.1% of the 5. So, when you, how would you find this person? It's very, very rare. I know that there are 25 donors in Jogja that are O negative, that are rhesus D, RHD negative. 25 donors. So, what should we give? Which blood type should we give? Tell me. Give a guess. You can't give a wrong answer. Is it blood type O? Is it blood type A? Is it blood type B? Is it blood type AB? Yeah, all blood types you can give. That's the happiness of being AB. We know that on the platelet we have antigens. And an antigen is everything which is potentially giving an antibody. So we have antigens, blood type antigens, and the blood type is nothing else than a few sugars, the A blood type and the B blood type. Okay, the platelet has no RHD, no rhesus D. We have HLA1, our tissue typing we have on it, and we know we have HPA antigens, human platelet antigens. I gave here a few, and we know about 35, 37 different antigens that are present on the platelet. And these are the platelet blood groups. Not the ABO blood group, but the platelet blood group, named HPA. How? What you do see is here another figure. These are receptors, because you need to know how a platelet is working. And these receptors have specific parts, and that are the HPA antigens. So our patient has blood type AB. So we can give every platelet, every blood type, what is available. What we also know is, in other literature, that when you give the wrong platelet, you are afraid of, because the donor with blood type A has an anti-B. The donor with blood type O has an anti-A and an anti-B. Blood type donor with blood type B has an anti-A. So why can we give this then? You should ask me, Dr. Hans, this is not right what you're telling me, because you have an anti-A or an anti-B. My patient has AB. I know. But in platelets, it's not that important. There are only a very few antigens, but we know that it can cause some trouble. We know that. We have a little bit lower increase of platelets. That's known. But what is better? Having a little bit lower increment, than that our patient will die of a bleeding in the bladder or the brain. We can't remove the brain after a bleeding. That's a little bit fatal. We know it's a little bit lower, and CCI is a measurement of the working of our platelets. We start with 4,000, we go to 50,000 with our platelet components, so we have an increment, an increase of 45. 50,000 minus 5,000 is 45. We calculate this with the body surface area, let's say 2, so we have an increase of 90 divided by the amount of platelets in the product. So we go about 10, 15 times compared to the body weight and the body height, we go up. That's very good. That's a nice increase. You see, when I give wrong platelets, I don't care that much with AB. Because what antibodies is your AB donor having in its serum, in its plasma? No anti-A, no anti-B. So I can give everything. And the minor incompatibility with the anti-A or anti-B in the plasma is not important at all for platelet transfusions. It's a very low amount. So don't do cross-matching, don't do typing in this case. Okay, we can choose everybody. So that's a release, but the D negative, that could be a problem, because what we know is that the D factor can give a lot of antibodies. And very quickly. Yes, we see this. But what we also know from the literature is that absence of the D LOE immunization is perfect. No problem at all. Sometimes you see it. And it's seen in several publications. And in the last review, it said that there is only a very small chance. And we recommend administration of anti-D if the D mismatched platelet concentrate prepared from whole blood collections are transfused to D negative females of childbearing potential. Is this lady from 67 years old able to get a child? Not anymore, eh? No. So we can give this. So, conclusions, the incidence between 0 and 20%, but leukoreduction reduces the rates, and yeah, we can better give an apheresis component. Now you can read it. There is a low incidence. Usually what you do see is that there is already an immunization in the previous time. And we should have leukoreduced apheresis platelets. So we can give everybody, every platelet. We need to test them, as I told you. And we prefer the corrected counter increment because this is based on the body surface. So when I give myself 300 times 10 to the 9th or 3 times 10 to the 11th, or I give you 3 times, that's a difference because my body is different. So calculate with this. Should we go? So this CCI should be above 7.5 or 24 hours later above 2.5. So it must be high. Below 7.5, when you have a transfusion, you give platelets, sufficient platelets, and there is no effect at all. So, what to do then? The patient is refractory to transfusions. Our patient, we have a problem. Pre-transfusion 4,000, but after the transfusion only 8,000, and she should go to 50,000. We have a problem. 24 hours later, we need already platelets. So even after 1 hour, we need already new platelets. This is not affordable, and that's becoming too dangerous. What if we do when we have no reaction? No reaction in platelet transfusions can be caused by several things. Think of a bleeding. Think of a sepsis. Think of other infections. Think of a diffuse interfacial clotting. And when you have this, you should give more platelets. But when you have antibodies, more platelets are also going away. So, why? Could be an anti-A, anti-B, then it's only once. Usually these are HLA antibodies. Could be also HBA antibodies. When 2 times behind each other, to avoid an anti-A and anti-B, to avoid this, 2 times after each other, below a specific weight, value is refractoriness. Usually it's HLA antibodies, sometimes HBA, and very rare it's HLA plus HBA. So this is the HLA system. This is a somewhat older picture. We know that on the platelet is only the HLA type 1, that is that part. So we have an A, a B, and a C. And the HLA2 with the DP, DQ, DR is not present on the platelet. So what we further know is that usually we have only antibodies against the A and the B. The C is not that important for the platelet transfusion. So we need an HLA-compatible donor. Why do we have HLA antibodies? Any idea? Why do we see this mainly in female patients and not in male patients? You study in health and you don't know the difference between a man and a woman? Come on. What can females do that men can't do? Pregnancy, indeed. And you're getting only pregnant as a female when you get something from a male. And together you make the child. So the child is a part of you and not completely you. So you carry for 9 months something in you which is different from yourself. So your child is an antigen. You can make antibodies against your child. And usually these are HLA antibodies or red cell antibodies. And Marga will tell more about that. Of course, blood transfusions can also give. So you ask your patient always, did you have blood transfusions in the past? And you want to know whether this was whole blood or leukocyte, so the buffer coat is removed, or the PRP product, or even leukoreduced blood, filtered blood. Some patients get because HLA antibodies because of kidney transplant or lung transplant. It's also very look-alike as you, but not the same. So in our case, I gave you the case that this lady was mother of 5 children. And we know from our studies that when you have had 3 pregnancies or more, there is 40% chance of HLA antibodies. 40. It's 4 in 10. That's high. But you have HLA antibodies. And now, what are you going to do? Oh, that's easy. You ask for HLA-compatible donors in your blood bank. Do you have them in Indonesia? Tidak, you don't have them. Absolutely not. Because this is never tested. So, we need an apheresis procedure from HLA-compatible donors, from our donor pool, but you don't have them. Who of the patient is very near to the patient in HLA typing, in the HLA type? Who of you is having a brother or a sister? I hear one yes. So, only childs here? Is this the policy of this university? Only childs?
Iya, kalau misalnya Dr. Hans nanya bisa dijawab langsung ya nggak apa-apa ya.
I think the majority of you has a brother or a sister, isn't it?
Yeah.
Yes, of course. And I think the majority of you has a papa and a mama. So where do you get your HLA typing from? From your papa and your mama. And where is your brother or sister getting his or her HLA system from? From the same papa and mama. So, who is the most ideal platelet donor in case you are refractory because of HLA antibodies? Your brother or your sister. So ask the patient when the patient is refractory for the brothers and sisters. And then, but you can only do this when you do cross-matching of platelets. Because you don't want to harm them, and you don't want to harm the patient with time loss. So do cross-matching and take, after a compatibility, do take from the brother or the sister. And when there are no brothers or sisters, or they can't give, okay, daddy and mommy. Or even, this lady had 5 children. Why not the children? Why should you not take the children in this case? Because I told you, probably she has had her antibodies due to the children, because of the pregnancy. So you can't take the children. But when needed, a brother or a sister of daddy or your mommy. That's also a possibility. Yeah? So, daddy or mommy and the sisters and brothers. Adult children you can test. Why shouldn't you test them? You can test them also, but after cross-matching only. And why not the partner? Your baby is part of the partner, and you got the antibodies because of your baby. So you got your antibodies from your partner. That's the reason you can't take the partner. So do platelet cross-matching. Preferably also irradiation. But that's not always possible here in Indonesia. But preferably. And check it, what it's doing. Always check, 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 check. So we have platelets needed to avoid problems in the baby. We need to avoid that your baby is going to get problems. You don't want that.
Excuse me, Dr. Hans. You still have 5 minutes more. Yeah.
Okay.
Thanks.
Maybe I skip this then. I want you I go to this one. I told you that we have receptors. And these receptors are needed for something. When we concentrate on these two figures here, together with that, you see that there is a breakage in one of the vessels. So the endothelial cells are broken. What's happening then? Material is coming free from the subcutaneous, from the layers below the endothelial cells, which is named the von Willebrand factor, and the platelets are sticking to that. And you need for that your receptors. But also what you see is they make a clot, and you have fibrinogen in between that, together. So when we go out, because of a fire, and we hold each other's hands, you can't go out anymore. So that's the reason that we should go out like this when there is a fire. The platelets stick together. These are the receptors. These are these receptors for sticking to the von Willebrand. So I continue with all. We need platelets from donors. We need HLA typing from donors. We need a compatible donor. This is not always possible, so brothers and sisters. And in case of a child, we take the mother. Because the mother is not taken care of in the fetal thrombocytopenia, but the mother has antibodies against the child. But I know that. So we take platelets from the mom to give to the child. The mother as platelet donor, she is always there because she gave birth to the child. She is negative for the platelets or the antibodies that caused the problem in the baby. And we can sufficient taking the platelets. A baby only needs 5 to 10 times 10 to the 9th per kilo. That's not that much. So we have some problems with the growth after that, so we need to take care of it. It could take longer. And potentially there are anti-A or anti-B antibodies or irregular antibodies. So take care. Washing platelets, we don't do it. We shouldn't do a hard spin. we add normal saline. This is not good for the platelets. So washing of platelets should never be done. And I think with that message, I finish my presentation. I give back the microphone to you.
Thank you very much. Give applause to Dr. Hans. Oke, tadi sudah membahas ya terkait dengan transfusi plateletnya ya. Silakan disimpan dulu untuk pertanyaannya ya. And you can ask to Dr. Hans in the panel discussion. But the second lecture from Dr. Marga van Hoes Sundeme here. The floor is yours.
Okay. Yeah. Thank you. It's nice to be here. And I hope that we can give our knowledge to you, yeah? Because in the Netherlands, we are doing this for a long, long time. And in your country, you just started 15 years ago, I think so. So we have a lot of knowledge to share, and that's why we are here for. So you can start it.
PowerPoint slide to Dr. Marga. Good laboratory practice in Europe related to red blood cells or platelet antigen testing. Is it right?
That's right.
PowerPoint slide? Okay.
In the early years, I was the head of the immunohematology laboratory in the Netherlands, and that's why I'm here. And now I'm working for reagents, but I want to share my knowledge. Well, normally when you're in the laboratory and you're doing the ABO, then you see only in your tubes a little bit agglutination. And when you do like this, you can see it. But after some times, you think, oh well, what did I see? I cannot show it to you, because it's gone. Did you have that experience too? Yeah, me too. So we thought, well, let's make something else. Let's make a card with tubes. They are solid, and you can share what you see. You can talk about it, and that's the most important of it. Well, our cards have components in 3 compartments. You have an incubation compartment, and you have your high density medium and your Cephurose gel matrix. In the first, you put your cells, your 0.5 red cells. You make them yourself or from the donor or the patient, or you have your 0.5 cells from the reagents. And you have your plasma, serum, or antibodies. Always start with the red cells. Do you know why? When you have your red cells already there, you want to attach your antibody on your red cell. And when you put your antibody on your red cells, it's going down, 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 down. Yeah? And it's attaching to all those red cells he's attached to. He follows all those red cells. And then it will be much more synthesized as the other way around. So keep that in mind. Well, in the incubation compartment, we put all those things, and then we centrifuge because we want to have all those material down. And then it goes into the high density medium, and in there you have an anti-IgG, an anti-IgM, and an anti-CD3. Well, it's there, and then when it's attaching and when it's doing, because when you have sensitive cells, it's okay, but IgGs and CD3s don't make a clot, yeah? If you don't add something to it. So we do that. We make the centrifugation step, and then you have a cloth. Well, these cells are laying on the top of the Cephurose matrix. And Cephurose balls are just little tiny balls. So after that, you have to centrifuge very, very hard, because when they are negative, they go down, and when they are positive, they stay on the top. So then you see the difference between positive and negative. So you synthesize them first. After that, you have to do deformation. Then you go back, and then you see your agglutination. And of course, then you have your result. 3 steps. You saw 3 centrifugation steps. The first one was to add the things together and get them into the high density medium. And then you synthesize the cells and the agglutination. And then the last one is a very, very hard centrifugation step to get all those cells through all those balls. Why isn't it working? It doesn't work anymore. Oh, a break. Oh. Oh, this was the... Okay.
I'm sorry, Dr. Mark.
Sometimes it happens.
Yeah, technical problem.
But you all do this, can do this by hand, yeah? Like you do it in the tubes. And it's the same work, but you can show it to each other. But now, hopefully...
Pak Kun?
Start again where you were.
Already. Okay, we can check.
Okay.
To the next slide.
Hopefully you can pipette that quick.
Is it work or not?
No, I had to go back.
Okay, maybe from this laptop, is it
no,
okay?
I know why it's coming. It's there are 2 films on it, and I think it doesn't work on your laptop.
Okay. Bisa nggak kalau dengan ini mak? Yang tadi di sini di escape bisa. Itu tadi kan udah buka.
Yeah, that's the first one, yeah.
Oh, this one for video.
Yeah.
Oh, video. Okay, so which one that slide you want to show to us?
All 2, but yeah.
Okay.
Let's start with the first one, yeah?
Nggak usah dibuka dulu nggak apa-apa videonya. Jadi kita ke yang videonya dulu, slide-nya aja.
So my
nanti dulu, jangan videonya dulu.
Okay.
Jangan videonya dulu.
If it doesn't work, leave it that way. Let's go further on.
Yeah, okay. Wait for a moment. Sampai mana tadi? Oh, this. Okay. Okay. This one?
No, no.
No.
2 more. Yes. More.
This, oh, more.
More.
Okay.
More.
This
Yeah,
one.
that one.
Okay.
There it is. What I want to tell you is that when you are looking at your ABO system, everybody knows there's an A, there's a B, and an O. But it's different when you're looking all around the world. How many people have the positivity for the gene, yeah? So when you look at the Caucasian people, and all those publications are mostly of Caucasian people, then you see that 43% of the Caucasian people are A positive. But when I go to America and I look in a place where there are a lot of American Indians, I will never find an E positive person. A B positive person neither. AB neither. Only 100%. Look at here. 100%. Oh, I always take the wrong one. Yeah. Look at here. 100% are O. So always be aware, where is the patient in origin come from? Most of the patients, of course, are from here. But sometimes they're coming from elsewhere. And then you have to keep in mind that there can be a change in genes. And also, when you look at the most important antigens of the rhesus system, you have the D, the C, the E, and the CE. And then you see the D antigen, and that's in the Caucasian population, 85%, for example. How much is it with you? How many people are D positive in your population? You say it, but I can't hear it. Well, it's 99.9%. So only 0.1% is D negative. That's not so much, yeah? So, do you expect that there are many people D negative? No. But you see a lot of D positive people, yeah? And when you are doing that in your tube, is there always a 4+ reaction? Always the strongest reaction. Do you see that always? No. Sometimes you see a 2+ or a 3+ reaction. And even 1+ you can see. Well, then you must be aware, because you have a quantitative reaction of the D and a qualitative reaction on the D. And what's the difference between those? Well, if you have a weak D antigen, there are less antigens on the surface of the erythrocyte. But they are the same as a people with a 4+ reaction, yeah? So no LO antibody can be made. But if you're looking at somebody with a D variant, you also can see a 2+, a 3+, or a plus. Then there is something different, because they are missing some epitopes. And you can make an LO anti-D. And this is how that looks like. This one is a bold one. There are no D antigens on the surface of the erythrocyte. This is a normal D antigen. You see, with all antigens, a normal amount, and this is the normal antigen. When you are weak D, you also have a weak reaction, yeah? But it's normal because this antigen is the same antigen as this one. So if you transfuse this one to that one, no LO antibodies can be made. But if you have a D variant, then you see a part of it is changed. And when you transfuse this one or this one to this person, he will make antibodies against this part of the D. So what you get is somebody who is D positive and has an anti-D. Have you seen it already? Yeah? And that's a problem, because you don't know why. How can that be? Well, this is the solution for your problem. Because the D anti-epitopes, there are 9 special epitopes we look at. And you'll see when you have a D6, and I think you know those, but there are more than that. You see, this one is missing some epitopes. And if you look like this, it's the same model. This is a D6, and this is a normal D antigen. And when you transfuse this complete D to this person, then this person is making an allo anti-D against this, and this part. So that's why you see a person with a D and an anti-D. If you see those 2 and 3 pluses and 2 pluses, you can look at this. You can take a polyclonal and a monoclonal and 2 controls. If it's positive, negative, that's normal, that's a rhesus D positive. If everything is negative, yes, rhesus D negative. But then, if you see the polyclonal is negative and your monoclonal is positive, then it most possible is it's a weak D antigen, yeah? But the other way around is that you have a polyclonal positive and a monoclonal that's negative. And that's because a monoclonal is only made against a few epitopes, or sometimes 1 epitope. And then it's missing because those epitopes are not there, and then you have a possible variant. And what's the story about this? Well, when you are a donor, then you are rhesus D positive. If you have a weak D, yeah. But if you have a variant, then you are also D positive. But when you are a patient and you see a 2 plus, a 3 plus, or a 1 plus, you must be aware that something like this can be the matter. And then you have to transfuse this person with rhesus D negative. Although that's very hard, I know, but you have to do that, especially in women, because they can get pregnant, and when they have a D positive baby, if you are D negative, then you have a lot of problems, yeah, when you have an anti-D. So you don't want to have it. So that's why it's important. And also, when you look at the other ones, it's also important to see what you have to do. Here, normally you look at your rhesus D, and the other ways, the other rhesus part you don't look at, I think so. But it should be nice if you look at your big E and your little c, because they are very genoimmunic. So you must look at that in the patient, but maybe in time it's also wonderful if you could type all your donors for that. So then you can match them better. And why is that important? Because sometimes you look also at the direct and the globulin test, yeah? Well, what are you looking at then? You look at that time if there are sensitive cells, yeah? That's what you're doing. At what temperature are you doing that? 37 degrees? 25? Room temperature, I think so. And you're doing that together with your ABO, yeah? Well, if you have an IgM, it will react also. And room temperature is something else than our body temperature. So an IgM in room temperature is not relevant, because that's not working into your body. So you want to get rid of it. So we make cards also that when you're doing your ABO screening, your ABO rhesus D, you see extra bands. And then you know that you have a positive direct antiglobulin test. And when you take the other cards, and in this card there, again, In this card, there is no IgM. Then you lose your bands and can see that there's nothing wrong with your ABO. But then you have to look further because there can be an IgG, yeah? Okay. We normally look at women at 45 years and younger for C and E and Cal compatible. In your country, I would will say you can look at the C and the E. And why is that? We already told you about the anti-D with the woman, but for the little c and the big E, there's the same problem. So be aware that if you want to transfuse a woman in that age, you look at the C and the E to prevent antibodies and to have a problem when they are pregnant. Also, patients with already one antibody. It's better to look at the rhesus because it's well known that when you have one antibody, you make a second and a third much more easier than the first one. So you have one, you have another transfusion, you have two, maybe three. And when you are someone with sickle cell disease, or thalassemia, or MDS, or autohemolytic syndromes, you have a lot of transfusions, yeah? Well, and then after all those making antibodies, you cannot find one single erythrocyte component anymore to transfuse. So that's why we are doing this. Oh, and this is the machine we invent to do it not by hand, but do it by the machine. This film is working. So you put your cards on it, the same cards you are working with when you are doing it by hand. No, let the music go. And then you put on in your samples. Your samples are there. And then you have your cards with the results here. And how it's doing is pipetting in here. This one is better. And after this, well, you see, it was pipetting the whole thing, and he read it also. So here he is reading, and then you have your results, and you can send it by computer to your other computer system if you like. So you can do this very easily. I shall skip those because it's not for you. And you can also combine, if you have a lot of donors to do, you can combine 4 machines with one computer. And this is what he can do, but we will not tell it now because we have to skip it. I think so. We go to another test. And that's very, come on, the MOSPAT. A MOSPAT is a test, is a monoclonal antibody solid phase platelet antibody test. So when you have refractionaries with your platelets, then you can cross-match for the patient. And we have an ABH, Lewis P1 and an HLA class 1. And you know they are all on the thrombocytes, but also APA. Dr. Hans was already telling us. And there are a lot of them. So, well, it's the same picture, but only not in color. You've already seen. So there are a lot of antigens there. When you want to see, and what I already told you, there are differences when you look at the APH in different. And this one is not working either. But if you look here, there's 72%, and here in this population, there's only 89%. But if you look at other places, you see more differences between the Caucasian and your population. And that's why it's always important to look at what is the origin of the patient. Well, for patients with a low platelet countlet, we always have to impaired platelet function. And 28 to 44% of the platelets, you see, they don't work. So what are we going to do then? There is an increased risk for mortality and morbidity, but also a longer stay in the hospitals. Because when you're ill, you stay longer in the hospital. And higher costs. And not only that, when you have a baby or somebody suffering, there can be a lot of more damage then, than only that. So we have a test made because normally sepsis, fever and active bleeding and drugs are there, but also the immune causes. And that's why we are looking at this. It's a solar phase technique and it's working like this. Everybody who has done the tube test can do this also. You have your platelets and that's coated. You put your platelets you want to give to the patient, you put it in. Then you wash it, centrifuge and wash it. Then you have the patient serum with the antibodies. Then you have to incubate it with IgG, and after that you put your red cell indicators with it. And after that you read your results. And in 90 to 120 minutes you know which platelet you can transfuse without any refractories. And that's very important because platelets are very expensive, So that's why we always sell. This is the negative, these are the positive and the weak positives. And that's much easier to read. You can read it by eye or by dream. So then you have a patient need platelets, and then the lab performs the mass spot, and you have a good course match. And it increased the chance of successful platelets, of course. Maybe he makes another antibody, but it's not hopeful. And it saves you a lot of money and a lot of illnesses. Well, it's fast and it's flexible. You can do it right away. And you don't want to avoid this, You don't want to have this or this. And that's what can happen when you don't have the platelet in the right time. So 90 to 95% of the antibodies are HLAs and 5 to 10 only APH. But you can all match them into this one. Well, if we look at how it's going. Oh, this one is also maybe nice for you. There are some publications you can read, and you can read all about those tests. This is the test, how it works. This one is your coated solid phase. This is the IgG. This is your LIS. This is your positive, negative reaction. This together you can stay for 3 months. And this one you have to replace every month because that are the indicator red cells. And they don't keep that much. 4 weeks at least, 5, and then it's done. So that's my story. So you can do better, but you have to invent and invest. That's true, but it's there. And make a start somewhere. Yeah? For you all, there's always a solution for every problem. Thank you.
Okay, thank you very much, Dr. Marga, for your explanation. And we are entered to next agenda. Will be held the panel discussion. It will take around 10 minutes to discussion. and you can ask to Dr. Hans or Dr. Marga. Please raise your hand. Okay, 1, 2, 3. Okay, maybe. Please tell your name. Yeah. And your question to Dr. Hans or Dr. Marga, you can tell with us. Okay.
Dr. Hans. Dr. Hans. To
Dr. Hans. Okay.
My name is Natasha. I have a question. Correct me if I'm wrong. We know platelet express ABO antigens, but not express rhesus antigen. My question is, if patient get platelet transfusion without look rhesus antigen, that can happen allow immunization? Thank you.
It's a little bit difficult to understand, but I think that you asked whether a transfusion, a platelet transfusion, can give an alloimmunization. Is that correct?
Apakah ini pertanyaannya tadi sudah, ini belum tadi yang disampaikan sama Dr. Hans? Atau diulang lagi coba? Pertanyaannya apa tadi? Efek dari platelet transfusion to... Maskernya dibuka biar lebih jelas.
My question is, if patient get platelet transfusion without look rhesus antigen, that can happen allow immunization?
Whether patients in blood transfusions can have alloimmunizations because of the blood transfusion. That's what I'm hearing. Yeah. So the question is very important. Yes. So every transfusion is bringing foreign antigens in your body, and you can make antibodies against that. For the D factor, that's between 50 to 70% of the transfusions you will get, you will make an anti-D. It's also possible for the big K, the Pickel blood group, in about 5%. And the small C, it's about 3%, 2%. And then the big E, also about 2%. So in 2 in 100 transfusions, you will get with the E, wrong big E, compared to your own antigens, an allo reaction. So you will make antibodies. Yes, is the answer. So.
Okay. Okay. Our next question. Sini Bu. Sini dulu sini, yang sebelah kanan.
Okay, thank you very much for your time. I'm sorry, I'm so nervous. My name is Sulis. I'm from North Malukas, the east part in Indonesia. My question is, Mr. Hans and Miss Marja, have you ever found the cases of the patient who was seriously injured and bleeding continuously while his platelets is normal? If ever, why? How can?
Maksudnya Dr. Hans and Dr. Marga ever find or meet with the patient?
Yeah, ever
with
found
a
cases?
Oh ya, cases about cases for? Cases apa? Kasus apa?
pendarahan pada pasien.
Or bleeding at the patient.
I'm sorry.
Did you ever meet
I'm sorry, my English is so bad.
bahasa Indonesia?
It's a bad noise and everything is going around, so I could hear it. So tell me.
More nervous ya?
You in there, I'm so never. Have you ever found a case
Yeah.
of patient
Yeah.
who was seriously injured and bleeding?
Yes. Massive bleeding.
Yeah.
Yeah.
So seriously and so many.
Bleeding from everywhere.
Yeah, in everywhere. But well, his platelets, it's a normal. If you ever meet that, how can like that? Okay, thank you.
A very good question. Very good question. Did we have ever cases of massive bleeding? Yes, we have cases of massive bleeding. And when you have a massive bleeding, you have severe problems sometimes because you need to take, first of all, plate of the tubes before you give any blood transfusions. Otherwise, you don't have the blood type. So, massive bleeding, we don't use whole blood anymore. So we have red cells, we have platelets, and we have plasma. And we transfuse 5 units of red cells, 5 units of plasma, and 1 unit of platelets. Your question is now, that's one step back. What we further give is fibrinogen, and we give other medication to try to stop the bleeding, to shrink the vessels as much as possible to avoid low blood pressures, filling the patient up. So we continue with that scheme of 5-5-1. But your question is then, in the beginning, you have high number of platelets still. So when you have platelets are not only in the bloodstream. Platelets are also a lot in the spleen and in the lungs. And when you get a bleeding, the body is thinking, oh, I have a bleeding, I have a severe bleeding. Come on, with all the platelets which is possible. And they push out of the organs, out of the bone marrow, so you can have, in case of severe bleedings, rather high platelet numbers in the beginning. But they will drop down very quickly because you lose them. Is that an answer to your question? So they come, the normal number of platelets come because the platelets come out of the lungs, out of the spleen, out of the bone marrow, into the bloodstream again. Is this an answer?
Yeah. Thank you.
You're welcome. Or should I say sama-sama?
Yeah, that's right. Oke, lagi once more. Cowok ya paling ya. Oh ya tuh tengah.
You can see that behind.
In the middle. Oke.
Thank you. Good afternoon, everyone. My name is Tika Andani. if we talk about transfusion intrauterine, that need to increase hemoglobin value on neonates. So the question is there any platelet transfusion intrauterine to increase platelets value on neonates? Thank you.
Platelets transfusion to neonates?
Yes.
Yes. Yes. Really good question. I need to think. Yes, we give platelets to neonates. Of course, when you have antibodies against platelets already, when the child is still in utero, in the womb, the platelet count can be very, very low. And Marga showed the CT scan of the brain of a child, and I showed also a picture, and Marga showed also a picture with all kind of bleedings. And then you need to give platelets. But you can't give normal platelets. So you are so lucky here that you can give PRPs. One PRP is about 50 times to the 9th on platelets, which is sufficient for a child up to 5 kilograms. So you can give platelets to neonates also, yes. And sometimes it's needed. When you have a bleeding or you have insufficient production, so when the bone marrow is not completely working, or you have antibodies, or the mother did use some medication, or the child is sick in another way. When a child has an infection, it has also low platelet counts. So yes, it is sometimes needed.
Thank you.
Oke, satu kali lagi ya. Siapa ini? Sud mungkin.
I will come to you.
I'm sorry. So, my name is Arya. First of all, I want to say sorry because my English is not good like my pronunciation. So, I will try my best. So, the question from TBD, to Dr. Hans. So, how we can determine that patient with platelet transfusion happens? Platelet transfusion refractoriness, it just indicated by CCI, or are there any other indication? It's just CCI or ada lagi?
And she's not willing to tell herself, to ask herself? You were pushed to do that?
I'm nervous.
No, okay, yeah.
Thank you.
You're welcome. You check your values. You check your laboratory. You check your complete blood count. So when you check your blood count on HB, on hematocrit, you see also a platelet count. So when the platelet count is going from, let's say, your platelets are 9,000, and you give a unit of platelets, and usually they give here anywhere between 8 to 10 PRPs as one standard dose. And this person will rise with this standard dose to about 50,000. You don't do a CCI. You only look at the complete blood count. So you follow the complete blood count. The next day, the platelet count will be 40,000. Then the day after, it will be 30,000. After that, it will be 20,000. After that, it will be 10,000. Why is it always around 10,000 going down? Do you know that? Our platelets are there to have to continue the integrity of our vascular system, the integrity of the endothelial cells in the bloodstream. So, when I do this, I have a bleeding. And my platelets take care of that. So we all use here between 7,000 platelets per day. So your platelet will go down. But when are you doing, so you're checking this with a normal CBC. And when it's coming or going below the 10,000, you ask for new platelets. You will give new platelets. But when you see it's coming from the 5,000, and with the same dose, it's only going to 7,000 one day later, or even 1 hour later, then you're going to calculate the CCI. Then you're using that. So your platelet indication is not based on the CCI. Your CCI is only to make a decision, I need other platelets in the way of HLA typed, or in your case, platelets from brother or sister. We always calculate normally with the CBC, the complete blood count. Is this an answer?
Yes.
Should I ask you, is this an answer?
Yeah,
Your
thank
neighbor.
Okay, give applause to Dr. Hans and Dr. Margie. Dr. Margie, do you want to?
Yeah, I want to tell you something. In the Netherlands, we have a book, and that's special made for people who are technicians, but also for doctors. We translated that in English, but that's not so good for you, I think so. So MLK and Dr. Tagun, they translated it in Bahasa Indonesia. It's not already printed, but soon it will be there. And you here, Francesca, or you, receive one. And maybe you want to show that to the students, and maybe you can teach something out of it. And that's why we're giving one away. Yeah?
Thank you, Dr. Marga. Excuse me, we have student from Timor-Leste, our neighbor country, and she would like to ask with you. Is it okay? Okay. Mana?
Ya, terima kasih atas kesempatan. Mohon izin bertanya dalam bahasa Indonesia. Perkenalkan, nama saya Joninya Ursula dari Timor-Leste. Mohon izin bertanya. Pertanyaan saya, dalam kasus demam berdarah, dokter selalu melakukan permintaan crossmat, platelet, dan kadang sehari bisa lebih dari 3 kali. Apakah itu normal dan tidak berpengaruh pada pasien? Pertanyaan saya yang kedua, apakah platelet bisa ditransfusikan dengan golongan darah dan resus yang berbeda, sedangkan dalam crossmat minor akan terjadi, pada crossmat minor akan terjadi aglutinasi atau reaksi. Jika bisa atau jika iya, apakah kedepannya tidak berpengaruh kepada antibodi atau kondisi pasien tersebut? Terima kasih.
Beri tepuk tangan dong. If there is platelet transfusion, and then it will give to the patient with dengue fever, and dengue fever, and is it correct or not, and what is the effect of that? Okay, so this is the first question.
Yeah. And you had so many words for that. it's translated into... patients with dengue hemorrhagic fever are well known to have in their need for platelets. So, yes, it will have some impact because there is a bleeding. There are all kind of bleeding sites. So, yeah, you need to give them for the integrity, and it will go down a little bit, but you need to give them in a higher dose. So you could decide to give in the morning at 8 o'clock or 9 o'clock, 8 to 10 units, or in the afternoon, 8 to 10 units. So a little bit more platelets in this case. But you don't have them. in the period of dengue, so in the dengue hemorrhagic fever also, it's a little bit harder to find your sufficient donors. So you can also ask then for apheresis platelets. Apheresis platelets come from one donor and replace 8 to 10 donors. So it's the same amount of platelets, and PMI Cotegade, PMI Sagittò, they all have it. So, really needed.
Okay, the second question, Dr. Hans. If the platelet transfusion gives to the dengue fever patient, and some doctor in Indonesia, they give or order to the blood bank blood bank technician, and then the doctor order more than 3 times. Is it possible or not?
Yeah, so it's our task to tell him then, that's right, doctor, what you're doing. But don't give it in 1 time, give it in 2 or 3 times. So giving a higher number, so it's not 1 times 600, but 2 times 300. Or not 1 times 900, but giving 3 times 300. So that's what I'm meaning for in the morning and in the afternoon. You give the same amount as you always give, but otherwise everything is gone in the evening. So you need to give in a higher frequency, not in a higher dose, but in a higher frequency.
Ya, jadi bertahap ya untuk pemberiannya. Okay, thank you very much.
Good question also. Yeah, really good questions.
Okay. Okay, give applause to Dr. Hans and Dr. Marga. Thank you very much. And thank you very much for your attention. And also, please to sit, Dr. Hans.
I want to say something, if you agree. Marga and I brought you some knowledge. And it's not our intention to give you our system. It's the intention in helping you realizing what's able in your population. So watching your population and what's happening in your groups of peoples and your city, that's more important. And we hope to make you aware that the information we give is helping you to think. You're intelligent enough in working in that field. That's our aim.
Okay, ladies and gentlemen, before we are closed, we would like to invite Miss Ida Nursanti and Dr. Hans, because we will give you some souvenir to you. Di atas saja. Oh. Okay, di sini. Dr. Hans, okay. Souvenirnya mana? Dari sini, Bu. Ini apa? Okay, group photo, Vice Dean and Miss Siska and Dr. Marga, Miss Ida, and Dr. Hans. Please do group photo together with the Dean and the Vice Dean. Okay. Di mana untuk fotonya bagus sini? Oh ya, at the middle. Yeah, in the middle. Yeah. Okay, thank you. Oh yeah. All right. Okay. Do you want to take photo with our students? Of course. But in the below of this. Yeah. Okay. You can go to down. Ibu-ibu bisa berdiri di sini. Nanti fotonya kalian berdiri aja di belakang. Nanti tukang fotonya di depan ya. Oh, at this you can like this stand up in here and then the student below you.